Hi everyone, welcome to Access Descriptor. This is our third case presentation. Let's start the case presentation. If you miss watching our previous two case presentation, we pinned in the comment section. You can go back and watch after watching this video. Okay. So as usual, guys, we have one case in our hand. I'm going to give a basic intro about the patient, and you can ask me the questions as usual as much as possible. We'll come into the diagnosis and treatment, what we learned from the patient. Okay, one 20-year-old male javelin thrower, okay, state participant, came with a complaints of right abdominal pain, bilateral abdominal pain. Right was more, and recently started developing right shoulder pain. Okay, past 9 months of right abdominal pain, bilateral, right was more, and then recently started developing right shoulder pain. Now we can start ask questions as much as possible.
What is his past medical history?
Past medical history, 1.5 years, 2 years before, he had a mild hamstring strain on the right side and anterior knee pain on the right side, very mildly, but he didn't take much attention to that. Just go with the flow. Just his pain is not give that serious trouble to him. He continued to play.
Since how long he is practicing the javelin throw?
Past 5 years.
So what's the intensity of the pain at the lower abdomen area?
6 out of 10 he mentioned.
And what about shoulder?
Shoulder he mentioned almost same, 6 out of 10. Recently started developing shoulder pain.
He was left-handed or right-handed?
Right-handed.
What is the location of the pain on shoulder?
Location of the pain is anterior shoulder aspect. Very in the abdomen, I'll say abdomen also. Abdomen is the pubic, just above the pubic, lower abdominal incisional area.
How he managed the pain for past 9 months?
Past 9 months, his nature of the character itself, not taking too much care of the pain, just go with the flow, that kind of person actually. Once started develop the shoulder pain, he came here, but he managed to throw, he managed to do all the activity slowly.
What was the
But-
aggravating factor?
But I want to share one thing, but his throwing velocity and potentially what needs to improve, all the component was slowly started reducing. Now he is taking care because of that.
And what was the aggravating factor of the pain?
Aggravating factor of the pain, throwing.
Relieving factor?
Relieving factor apart from throwing, almost.
What about sensitization?
Sensitization is very mild. That's why the patient took very 9 months larger period of time to taking care of this treatment. If it is moderate or high, it means you could have come early.
So you have told throwing is aggravating factor.
Hmm.
Is both the abdominal and the shoulder both is
Yeah,
the
yeah,
same
yeah.
aggravating factor.
Both same actually.
Does he have the fear of movement?
No.
Psychosocial factor?
Psychosocial factor is not affected that much.
At which point of throwing he has the pain, abdomen and shoulder?
At the stage of delivering the javelin, last stage of contact and delivering the javelin with maximum stretch position or elongated position to throwing stage.
Is he playing any another sports only or just the javelin?
Just the javelin throw, Rishabh, your question.
Did you check for any mobility test?
Yeah, mobility test we did actually. I'll show you the overhead squat looks like and what are all the findings you can able to make. We can make. Okay, fine. Come on, everyone can look it. See, when we look at the overhead squat, see he was sitting rotationally towards the right side. So there is high chance of mobility restriction on the left side, hip, knee, ankle. We have to check all the three components isolatedly to know where it is actually. Since it's a rotational shift, the high chance of knee and ankle involvement. Okay, when you see backward also, shifting towards the right side more. Okay, and we assessed him isolatedly as well. We assessed him isolatedly, hip, knee, ankle. There was an ankle dorsiflexion mobility restriction on the left side, and there was a knee flexion restriction on the left side. Okay, but here is an important question: is he have a right side? He has a right side javelin thrower. He have a right side abdominal pain and right side shoulder pain. Okay. But he is shifting towards the same side, which means mobility affected towards the opposite side. It doesn't correlate, right? It doesn't correlate. No, we could have expected to him shifted towards the left side, right side mobility restriction. Maybe we could have found out something. Then what we have to do next?
Strength testing.
Yeah, strength testing. So we did strength testing isolatedly and both integratedly. Okay, when we check back extensor endurance test, it was highly weak. Hardly he hold 40 seconds with a lot of vibrations, max effort. So as a javelin thrower, 40 seconds of back extensor endurance test is not efficient. One thing I understand. And other muscle group with both right and left leg comparatively, we did isolated each muscle test. Okay, here is a surprising fact that mobility was reduced a lot on the left side. Mobility was good on the right side, but completely opposite here is the stability aspect. It completely opposite here. When we check isolated stability, hip flexor, extensor, abductor, knee flexor, knee extensor, and everything is good in the left side. It's less in the right side
What about the rotators, internal and external rotators?
of the shoulder joint.
No, of the hip. Yeah, assessed no.
Internal external rotator of the hip also assessed. We assessed that is also weak. On the right side is weak compared to the left side. Left side he is strong. Since Agilan you asked about internal external rotator, we forgot to talk about shoulder here. We forgot to talk about shoulder here. And shoulder also, when we assessed a classic javelin thrower or throwing shoulder, he was present. Reduced internal rotation, range of motion, grid positive, and external rotator strength was weak. When we test external rotator strength was weak, and overhead mobility also restricted. Scapular dyskinesia is noted on the isolated side. But we can't completely say that this is the sole reason for this all the biomechanical factor which has happened to him is not the sole reason for the shoulder pain. Why I'm saying this? Because shoulder pain started later after the abdominal pain. Maybe it could have developed, it couldn't able to throw insufficient rotational throwing capacity. Maybe later shoulder pain started developing because of the throwing velocity. But usually every throwing sport athlete have this kind of abnormality. There is a criteria in a preventive state criteria. So shoulder pain you look at lately. I'm thinking this could be the shoulder pain reason.
As you mentioned that this is a rotational sport, did you test his rotational strength? Or
Yeah, we tried testing the rotation. Here there is an important thing we need to discuss. I didn't mention the adductor strength, right? Abductor, reflexor, extensor, everything is weak. I mentioned. I didn't mention adductor. When we check the adductor, side plank adductor test. When we check the side plank adductor test, he showed left side side plank adductor test strength tests provocate the pain more compared to the right side adductor. So then we check the adductor isolatedly. And check the isolatedly what it shows. Both side adductor is weak comparatively. There is no side to side difference. Much side to side difference. Both side adductor is weak, but there is no pain provocation. Isolated test doesn't provide any pain provocation, and rotational side plank raise adductor test functional chain shows some pain provocation. So do you know what could be the reason? He have a right side abdominal pain. Why he has a left side side plank adductor test pain provocation more than the right side side plank?
Is that functional chain
involvement? It was involvement of functional chain, external oblique, internal oblique connection. Another function, there is a lot of myofascial connection. There are so many authors are explaining. Functional rotational chain have a lot of evidence too. So it was connected, this external oblique connected to that opposite side adductor. A rotational functional chain. You have lower pubic regional pain. That is where the connecting point from the adductor to the opposite side abdomen. So maybe that's the reason for left side adductor and this abdomen has a good correlation. And one more thing, all the other muscle groups compared to the right side, left side is little stronger, except the adductor, both side is weak. So since it's a javelin thrower, rotational sports, so adductor, abdomen, chest, pec muscles, and extreme external rotation of the shoulder during the cocking phase of the javelin throw, it happened. Right, so this entire region was involved. So as we come to the point, maybe abdominal pain started. That's why he started developing later shoulder. Could be this. We have to find out here why abdominal pain he has. Now we are coming to the another important point. So you have a lot of mobility stability restriction. Right, all right legs have less stability. Muscle was not that strong. And even when he was lie down, right leg was completely lagged and external rotated compared to the left leg. And coming to the left leg, whole left leg have less mobility and good stability and good strength except the adductor. Okay, so what could be your diagnosis so far? What was the diagnosis? Why he had that issue?
So it may be because of the sports, because what he's playing, sports demand.
No, he was playing past 5 years, right? Why suddenly he has to develop one side abdomen?
Maybe we want to add the mobility stability.
Yeah. maybe as a common physiotherapist, one person come with the complaints of abdominal pain and shoulder pain. As soon as looked at that leg mobility, stability, lot of compromission over there, first thought process goes to that physiotherapist is to correct that mobility, stability issue, everything. Then only your pain will go out. But here is completely different. According to me, my understanding is mobility, stability, lagness between the right and left leg is not the true diagnostic. It is not adding any diagnostic value. Even though after treated 2 weeks of rehabilitation, he was better. He can tow well, reduce shoulder pain, reduce abdominal pain, but his mobility stability is still same. Difference was still same. Nothing is improved, but his pain is improved. So the diagnosis is not directly related to this mobility stability.
Then how did the pain start?
The pain start here. There is an important question no one asked. Very important question. He did 9 months before. He did 15 minutes plank session, core strengthening, extreme core strengthening, and plank session. Immediately after that, the coach asked him to throw. Kept a throwing session. That time he had an abdominal strain, lower abdominal strain, and also frequent elongative movement. Due to frequent elongative movement, the entire functional chain when we test it was weak as well. And adductor also opposite is weak. So it's pure functional strain involvement, just an abdominal strain. We activated the abdomen, adductor, muscle strength, and every lower abdomen and rotational functional chain. Immediately he feel better. Within 2 weeks of rehabilitation, he started feeling better, throwing and everything. But the mobility stability is same. So not always the mobility stability restriction will cause the pain. There is hundreds of people roaming outside, thousands of people roaming outside. You go and take randomly 10 people and check their mobility. The people who doesn't have any pain, definitely there is high chance of restriction in the mobility stability. Couple of peoples, but we can't say them come and give. I will give exercise. In future, you will get chance of pain. Maybe there is a risk factor of pain for him also. That can be a risk factor of pain. That is not a sole reason. What I am saying is, after that correction, shoulder pain also started reducing. So now we understand the diagnosis. After that correction, shoulder pains also started reducing. So shoulder mobility stability restriction also not cause shoulder pain. Yet all the structural changes for mobility, stability, everything for him is sport specific in nature. Because left leg stability was good because impact leg while throwing, frequent impact, improve the leg stability. Rotation, excessive external rotation to come to this leg, internally rotate, have a good mobility. Frequent impact, have good stability. It's not like this leg is weak. It's normal leg for him. The left leg have a frequent high impact, so it was stronger than this leg. So we can ask him to personal suggestion. You have to correct this mobility stability to make your external rotators a little more stronger, to make your other hips more mobile. We can suggest it to prevent further injury, further sports related injuries.
Maybe this could be the reason for his previous hamstrings.
Yeah, maybe. It is now there is no context. We don't have context. But one thing was sure: previous history of hamstring and knee pain, it's not related to the abdominal involvement. Now current pain. Maybe the mobility stability restriction can be a reason for previous history. Now we can't find out. If we need to find out 1.5 years before, we have to go and ask him and to rule in, and we can find out. Now it's impossible to find out the reason. Not impossible, almost difficulty to find.
So in this case, the load management plays a major role because he overloaded and he went for the throwing. So it makes
exactly. Perfect, Emmanuel. As Emmanuel said, load management is the potential risk factor actually in sports related injury. So if you could have avoided throwing after the high plank sessions, high intense plank sessions, you could have avoided that injury.
So did you do any exercise particularly for shoulder?
No, we didn't do anything to shoulder. But that is the beauty of this case. We didn't treat shoulder, but shoulder pain also reduced because because of the abdominal pain, he used more shoulder, overuse pain again shoulder. Now we treated the abdomen. He was throwing with a good rotational kinetic chain force. Shoulder pain started reducing. Research says that when we throw, 20 to 25% of the force is generated by the shoulder. Other 80% of the force is rotational force generated by the kinetic chain, rotational kinetic chain. So basically, for summary, we treated the exercise like adductor activation, lower abdominal activation, and rotational functional chain strengthening exercise we given to him, he felt better quickly. But even I thought that we have to treat that mobility stability. Even I confused that when I assessed the patient, he shifted towards the opposite side. What is happening? Test mobility. We come up with answer. Yeah, by session we'll get some information. That's why I always insist everyone. Every session is assessment. Just 15 minutes, 10 minutes discussing with the patients, talking to the patient. Don't come to conclusion. Just explain to them whatever the thing we found out. That is the key. Make them understand about their problem and ask them to come session. Assess more, treat more. Assess more, treat more. Repeat the process, patient will improve.
I have one doubt.
Yes.
He's a state player, so every day he will work out, right? So he also do some core exercises, some leg strengthening. Why not the pain get reduced in the past night?
He don't know, right, actually. Where to activate, how to activate, how many repetitions. Everyone knows how to take, if I have some fever or something, I can take antibiotics or paracetamol. At what age, when you have to take, how long rest interval you have to take, how continuously you have to take. Doctors knows very well, according to our age. So he was following the repeated throwing, whatever the coach says. What was the Indian coaching mentality attitude? You have to understand that, right? Whatever pain you have to do. Then only you will become a good sportsman. You have to sacrifice the pain. You should not show pain. And students also have whatever coach says, we have to blindly follow. That is the main reason India is not outperforming the other countries in Olympics. Now slowly we started growing.
What was the difficulty you faced while reading this question?
Yeah, difficulty means simply difference of opinion every session. First session we thought that mobility, the confusion. Second session, one by one we assessed. Each session we assessed. We come to final conclusion. We are explaining to them. But this was difficulty I faced. Lot of confusion between this understanding the range of motion aspect, strength aspect. Why he had this pain? Why he doesn't have this? This was the biggest confusion which I had.
What was the learning from this case, sir?
Learning very simple. I always say when there is a mobility restriction, don't blindly rely on the mobility. It's not the only reason for cause of pain. When there is a palpation produce pain, don't blindly rely palpation is the reason for pain. When there is stability reduction, don't blindly rely stability reduction is the reason for pain. This case proved that strongly. Yeah, you're right. When there is a mobility stability restriction, you have to always correlate with this need, pain, and everything in detail, and we have come to a conclusion. Even though we didn't treat that mobility stability, he was improved. The strong learning from this patient. Hope this video on case presentation is helpful to you to improve your clinical practice. If you have any doubts, you can ask us in the comment section below. So see you in the next video.
Don't forget to like the video and share this with your community.
Most importantly, don't forget to subscribe.